While we wait for the presentations to start, please adjust your screens. We have some trivia to get us started. Please read the 2 trivia polls and show the results. Okay. I give a few more seconds. And here are the answers. And now trivia question 2. A few more seconds. Okay. Welcome to session 2 on non-clear cell renal cell carcinoma. My name is Maria Isabel Carlo, and I would like to introduce my fellow moderator, Dr. Adam Mitwali.
Good afternoon. Thanks for joining us. It's a privilege to be here, and it's my privilege to introduce our non-clear cell trial design roundtable with distinguished panelists, Darren Feldman, Hyung Kim, Bradley McGregor, and Brian Shuck. So I'd like to start with an initial question regarding the difficulty with pathologic subclassification of non-clear cell renal cell carcinoma. Since accurate pathologic diagnosis is the key for trial eligibility, and non-clear cell renal cell carcinomas are often sometimes difficult to characterize, how confident are we in biopsy-based histologic classification of non-clear cell RCC? Is central pathologic review necessary for a multi-center trial because of this complexity? I think we'd start with Dr. Shuck and then maybe work our way across the board. Does that sound reasonable?
Yeah, Adam, I think it's a great question. It's very challenging. If you're doing a biopsy, it's very different than a nephrectomy. A nephrectomy, you have a big piece of tissue to look at. A small biopsy in an aggressive cancer, there could be a lot of necrosis. We've also had times where someone does a panel of 10 immunostains and then they sent us a tumor for a second review, and there's actually not enough tissue to actually look at other than the initial H&E. So, these rare variant histological subtypes, I think it's challenging. It's nice if they've had a nephrectomy, but clearly that's not always possible.
Thank you, Brian. Dr. Kim?
Yeah, hello, everyone. Thank you for including me in this exciting panel. So I'd like to just, say there are challenges, but I think the tissues should certainly be collected. And even though they may not be used to prospectively stratify patients on a trial. Perhaps we can get some biomarker hypothesis generating data for the next iteration of a trial. So as a field, I think we're still in a tissue collection mode is my sense.
Dr. Feldman, any thoughts?
Sure. I agree with both. I think, though, it would be very useful to have a central review, not necessarily, again, for eligibility and stratification or assignment of treatment, but as part of a validation for what proportion of patients have a specific variant and it gets changed upon central review, and what are the reasons that happens. I think that even amongst the foremost experts in renal cancer pathology, there can be some disagreements on rare subtypes. So I think that would be of interest.
And last but not least, of course, Dr. Gleason.
Thanks. I certainly agree, and really feel that the more tissue for molecular analysis that we have, the better. And in particular for these rare variant cases where the pathology is so crucial.
And this is Brad McGregor. I would agree as well. I agree with Darren that I think collecting it and having this looked at after the fact is sort of important. I think requiring an upfront central review may delay things and delay the start. And patients with these rare histologies, these variants, kind of aggressive histologies, and so any delays in starting therapy can often lead to unease on the part of the patient. So I think having that central review that after the fact and sort of looking at it afterwards is certainly going to be helpful. But I think requiring that as an upfront step for randomization or enrollment can sometimes cause delays that make the patient uneasy.
My apologies, Dr. McGregor. I completely skipped over you.
Only other thing to add would just be the unclassified group is particularly relevant for central review.
So we have a question from Dr. Monty Paul from the audience. Should we get genomic profiling in those cases to supplement the pathology? And this is a question for all of you, but especially those that have conducted trials in non-clear cell RCCs where we use histology or genomics.
So I'd like to say, sorry.
Go ahead.
I think it's great to do it, but the question is who pays for it. There's definitely around the country, there's definitely reimbursement challenges in some areas and some patient populations. So if a trial pays for it, that'd be awesome.
I think that's an excellent point, Brian. As the chief of urology at Howard University Hospital, that's a chronic issue with these types of questions and our patient population, given the underserved patients that we treat, and certainly the understudied patients as a result. So this is certainly an issue. Dr. McGregor, you're nodding vigorously. Do you have something to add?
Yeah, I would agree. I think getting that information can be very interesting, but it's not standard of care right now. So getting it paid for can be challenging. So as we've developed some of these trials looking at novel options for patients with variant histology, that is something that, as we design a trial, we're asking for funding to get that information to help us go back after the fact and look for potential market response and help classify the histologies better.
And I also have another question for the group. So we were talking about, and I presume we meant somatic mutations, but we also have trials where germline mutations are an eligibility criteria, such as the ones NCI for HLRCC or the ones at MD Anderson for VHL and other centers. How often do you all send for germline analysis for non-clear cell renal cell carcinomas, especially in the advanced setting?
This is Darren. I would say that for any patient that's young, we would definitely send it. Any patient who has any syndromic features should definitely have germline genetics sent, and anybody with certainly with a family history of one of the syndromes. Beyond that, for germline at MSKCC, where I work, we have our somatic panel that's tied to our germline panel, and so it facilitates doing germline testing on anybody that we do somatic testing on, and we would try to get somatic testing on most patients if we could, be sure that their insurance would cover it, or if we had research funds to cover it.
I think in the regular community setting, if you're not familiar with any of these syndromes, it's nice as a default to actually send testing. But in an academic center where there could be cost as well, if you have a specialist who's seen 100 cases of Birt-Hogg-Dubé and your pathologist has recognized it, I think there you could be a little bit more selective based on histology and clinical characteristics.
All right, we have another question from the audience from Dr. Kim Rathmel. How do we get from central pathologic review to molecular review? Why don't we start with Dr. Kim? Do you have any thoughts on that?
Yeah, I think the group has already mentioned the barrier associated with doing that, and it's primarily cost. The technology is readily available. I think the trials in this day and age all need to collect tissue. So there's really there should be a strong emphasis on making sure tumor tissue and serum and whole blood are banked, and then the molecular pathology is going to, that's the kind of stuff that's going to provide future insights on disease mechanism. And then as the trial proceeds and we have better clinical phenotyping with follow-up and drug response, that tissue becomes more and more valuable. So I have a lot of optimism for the future given the advances in technology, but we're not going to be able to apply that technology, which is going to only get better and better unless the tissue's been banked.
And then, most therapies are getting a little bit more into clinical trial design. Most FDA-approved therapies are based on data from clear cell renal cell trials, or certainly the trials where the majority are clear cell. However, practically speaking, we all extrapolate from those trials to treat our non-clear cell patients. And, there's recently been a few great small trials with histology specific or molecularly specific, such as, for example, PapMet, which is for papillary only, or SAVAR, which was for MET-driven tumors. But the question is still, we have these large phase 3 trials and the infrastructure that comes with them. Should we be making efforts to include non-clear cell patients in those trials, for example, like Prosper is doing or Assure did?
Yeah, this is Brad McGregor. I think that's a great question. I think it's a tough thing to think about. If we look at the large trial right now in clear cell metastatic setting, Cosmic, looking at Nivo, Ipi, with or without Cabo. I mean, obviously that's a very intriguing idea, but I don't know, can we really say that Nivo Ipi is a standard of care for those with variant histology RCC? And I don't know if we can, because we just don't have the same level of data in that situation. So, what we've done is we've looked at an investigator trial of looking at the triplet in a phase 2 trial in patients with variant histology RCC, including all. So we're not limiting it to just papillary or just chromophobe, but taking all patients with variant histology RCC, just doing a single arm phase 2 trial of 40 patients open this past week. And I think that allows us to complement the phase 3 data. and get some information. And hopefully, based on that, we may see signals of response in some histologies, others that may lead to larger trials and more development.
You know, the problem with the aberrant histology is it's generally accepted based on retrospective data that they have a slightly worse prognosis than clear cell. So clear cell represents the majority of renal cell carcinomas. So there are ample numbers of clear cell patients for phase 3 trials. So if you're a drug company, you're not going to want to include aberrant histology. That may make your drug look less effective. So what you see as a general trend is pharma studies are exclusively clear cell, and cooperative group studies often include aberrant histologies because they want data on those patients. To me, a reasonable compromise is to include all comers, but maybe the primary endpoint can be driven only by the clear cell patients. That way you get the data and the tissue on the variant histologies, and then you marry that, as Brad mentioned, with smaller phase 2 studies to get really an answer on what happens in the aberrant histologies.
Yeah, I agree with that. And, you know, innovative designs which put, you know, a certain minimum number of patients with clear cell, for example, and then another minimum number of patients with non-clear cell, which could even be exploratory. And even within non-clear cell, I mean, it's one umbrella term, but obviously we know that there's a different biology within the different subgroups. And I think that's also an apprehension of pharma, is that, you know, even if you thought the drug might be beneficial or your drug might be beneficial in one subtype, there can be such heterogeneity across subtypes that it's a risky endeavor. So I think setting a minimum, like you said, of clear cell patients, but then trying to include some of these patients where the risk isn't felt to be so great that it outweighs the benefit, the potential benefit, is a good idea.
And there's a question from the audience, Dr. Martin Voss from Sloan Kettering. Can the panel comment on modular adapted designs and whether these could provide more flexibility? So for example, some of these allow for patients to be treated with different regimens serially within the same framework. Some examples of these are fraction in kidney cancer, also the big I-SPY trial in breast cancer. Could these strategies make sense for rare histologies where central path review would only be needed once per patient?
Absolutely. I think that's a great idea, not just because Dr. Voss is a close colleague of mine, but no, I think that's an excellent idea. And the other thing that I think really important to these studies is collaboration, because it's very hard with rare histologies to have, you know, everyone accrued at one center, you know, takes several years, whereas having patients accrued from either all over the country or all over the world can rapidly accrue to these rare histologies, especially if you are going to have specific cohorts, which I think, you know, we should think about chromophobe tumors differently than papillary tumors, and certainly differently than collecting duct tumors. And so cohort-driven studies that's really based on the biology, but testing each individual histology separately with some type of adaptive design where you can switch, you know, drugs that are working, you know, have an expansion cohort within a specific histology. And if it's not working with one cohort, then switch to another drug without starting over, I think would be great.
So there's a follow-on to Dr. Kim's comments from the audience about what your thoughts are potentially for a requirement for trials to accept non-clear cells into their trials, and they're obligated to then do genomic profiling to get signals for those patients. I think that's somewhat akin to what's been said before, but do you have any additional thoughts on that?
I don't understand the politics well enough to really answer that question. I think you can mandate something like that in the cooperative group setting, and I think if that's going to be done in the NCTN, just because there are academic physicians who are very interested in these questions. But when you're talking about industry trials, I'm not sure what the mechanism would be to mandate something like that.
And again, if for a molecular targeted agent, if it's been designed and studied in one cancer, I'd have a hard time recommending a patient to go on a study like that if it wasn't had any preclinical rationale for that specific cancer.
That's an excellent point, Brian. Another question for the panel from the audience. How much variation is there in genomic profiling results by vendor and by sampling technique? Anyone?
I'm not the expert on this, but I think there is a fair amount of variation. For example, Foundation One, which does somatic profiling, doesn't subtract out germline information. The MSK impact profiling, which I'm most familiar with at Memorial Sloan Kettering, takes into account germline and compares it and subtracts out germline so that it only would call somatic variants that are not present in the germline. So I think there is, and then of course the number of genes that are tested, the specific exons of the genes tested can vary. I think for the most common genes, there's probably not that much variation, but when you get into the weeds with some of the more rarer variants, I think there is difference, and also with the germline issue that I mentioned.
I mean,
sorry, go ahead.
I mean, I would tell you that, sometimes, we do confirmatory testing. When you send a tumor for like Tempus, you have them do germline, and it's kind of you're not sure what the reliability is. I mean, the companies like Invitae or Ambry have been doing germline testing. A lot of times the interpretation of the bioinformatics is a little bit different as well. So, obviously that adds a whole nother complexity, but we have sent tumors or germline to different places and have seen occasionally different results.
Switching gears briefly, I'd like to ask the panel a more general question about the elephant that's in the room. But what sort of changes have you had to implement, and what changes have you seen in terms of conducting clinical trials in this era of COVID-19 and with the expansion of telemedicine and that sort of thing? Dr. Shuck?
Having operated on a couple patients without having seen them, it's clearly doing a physical exam is very challenging over telehealth. So, when a patient shows up and their BMI is 10 points higher than they were advertised, it becomes a little bit concerning. So there is a physical exam is important, and I'm sure you can't diagnose probably a large pleural effusion without a stethoscope doing it by telehealth.
I would echo some of the echo Brian. I think before COVID-19, I've never had a patient who was willing to let me operate on them without meeting me in person. But I think it's becoming more common to see that scenario. And it just goes to show you that patients are becoming more comfortable doing things virtually. And so being able to consent patients for trials, being able to counsel them about surgery and make decisions about surgery all online is a very new era that we're in because of COVID-19. And so, COVID-19 is a terrible pandemic, but it has accelerated our use of technology for sure.
Do you think that it increases the margin of error or the variability in terms of enrollment, however? Because some of the things like Brian alluded to, where you get a little bit surprised when you actually see someone in person after not, going through the usual face-to-face multiple meetings. Is that going to make clinical trial accrual easier because you can reach more people? There's not sort of the queue to be evaluated, or is it going to make it harder because it's more difficult to distinguish who's actually eligible?
I would just like to say, DocuSign is amazing. And we've had patients contact us. We send them a DocuSign. They look at the consent, and they may start screening before they actually show up. So rather than flying into New York City to see Marie, potentially she's like, we have a trial. This is the consent. You can look into it, and they kind of come in all kind of tuned up. So if you don't have DocuSign approved, now is the era where you should push for it, because it's definitely for trials. We definitely have a great tool for these kind of programs.
Yeah, at least from the medical oncology perspective, and Doctors McGuire and Feldman can also chime in. I think patients are more willing, at least, so I practice in Manhattan. A lot of our patients live 2 hours away, 3 hours away. And a thing that really is a barrier is the travel. And a lot of our trials have, every 2-week visits, which are certainly important at the beginning. But, patients, I have some patients who've been on trial for, 1-2 years. And at the every 2-week visit is a burden. And clinically, some of these, I'm comfortable seeing virtually. So I think some patients have been more prone to enroll in trials because I tell them, we may be able to do some visits virtually and you don't have to come into Manhattan, every 2 weeks.
Yeah, I would 100% agree. I think if we can use telemedicine to complement in-person medicine, not replace it, I think there's certainly a way to improve the overall care experience for the patient. And so thinking about, when does a patient really need to come in? When could you do a phone visit with outside labs and check in on people? I think it's important as we look to design trials now, to think about those things, because telemedicine is here to stay, and incorporating that into design, incorporating that into a safe, effective plan for the patient will be pivotal to increase enrollment and allow patients to get their care delivered safely.
And I think we have just a couple of minutes left. So one point that Dr. Pal wanted us to emphasize, and I definitely agree, it's important. So, going back to the genomic profiling, recently Medicare guidelines changed to cover somatic testing for all cancers in the advanced, refractory, or metastatic stage. So, this doesn't necessarily apply to your, resected non-clear cell RCCs without any evidence of disease, but certainly anybody with non-clear cell who you're thinking of giving systemic therapy to, at least Medicare guidelines should cover profiling. And to add to that, the NCCN guidelines this year also changed to broaden germline genetic testing, especially to suspicious histologic subtypes. So if you have somebody with a tumor suspicious for germline, such as multifocal papillary, the NCCN guidelines do suggest genetic counseling. Ideally, Medicare should cover that, although I think to this date they haven't issued official guidelines to mirror the NCCN guidelines. And I think we're running out of time for this first half of the session. I just wanted to open it up for any other final comments from the panelists. If not, thank you all. There's some additional questions that are very interesting, but hopefully that can be answered in the virtual breakout session, I believe. But we'll move on to some presentations. So We have discussion of novel approaches in non-clear cell renal cell carcinoma. So for this section, there's 4 pre-recorded videos from Drs. Mark Ball, Dr. Aixen Oy, Jack Gleason, and Matt Campbell, which I encourage you all to watch if you haven't already. And now I'm going to hand over the slides to Dr. Ball, who will be discussing first management of multifocal RCC and giving us a brief summary of his presentation.
Thank you very much, Maria, and thank you to the KCA for the opportunity to speak with you today on what I think is an important topic, and certainly a topic that I spend a lot of time on in my clinic. So multifocal RCC is really defined as more than one renal tumor in the same kidney. And it is not a rare entity. It's found in 6% up to a quarter of cases of kidney cancer. And there's really a strong association between multifocal kidney cancer and bilateral kidney cancer. In fact, at autopsy, 90% of patients with multifocal disease have evidence of bilateral disease involvement, which has implications for the way we manage it. Multifocality can be caused by several mechanisms. We all know about hereditary kidney cancer, but also sporadic de novo tumors seen very commonly in papillary type 1 RCC, satellite lesions from big tumors, and intrarenal metastasis. And was, as mentioned in the last session, the workup for multifocal RCC should at least include an evaluation for hereditary kidney cancer with history and physical and discussion of germline genetic testing. The treatment of multifocal has traditionally been with radical nephrectomy, despite the fact that there is equivalent oncologic outcomes between partial and radical in this population. And size for size and stage for stage, there's really no difference. But given that association between multifocal and bilateral disease, many patients who are treated upfront with radical nephrectomy may later need an intervention in a solitary kidney. And as we heard from Dr. Campbell this morning, that can be a difficult situation to be in. So papillary RCC is the most common multifocal tumor that we see outside of hereditary kidney cancer. Over a third of multifocal cases has both sporadic and hereditary forms. It's more common in patients of African descent. And at least at my institution, at the National Cancer Institute, we treat multifocal papillary kidney cancer the same way as we treat hereditary kidney cancer. And when treated when small, these patients have a very low risk of metastasis, 0 when it's less than 3 centimeters. And the last point I want to emphasize here is that there is some activity for systemic therapy in localized papillary RCC. And this is with MET inhibitors. And there have been 2 phase 2 trials looking at localized papillary RCC. But there are divergent responses based on MET status. So Schwer and colleagues evaluated retinib in papillary RCC. And even though the overall response rate was only around 13% in their trial, in patients with a germline MET alteration, 50% of those patients had a partial response. And finally, an INC280, a selective MET inhibitor that was presented at GU ASCO earlier this year. Again, in the entire cohort of papillary patients, overall response rate of around 15, but that doubled to around 30 in patients with a MET alteration, mostly germline. So I encourage you to view the rest of this presentation and the online supplementary material, and happy to take questions at the end of this session. Thank you very much.
Now we'll have Dr. Oy present a summary of his presentation on NRF2 and biallelic FH inactivation.
Thank you, Marie, and thank you, KCA, for giving me this opportunity to share with you some of the latest findings in the lab. I'm going to switch gear and talk a little bit about some of the preclinical study and the biology of HLRCT. Hereditary leiomyomatosis and renal cell cancer, or HLRCC, is a autodominant hereditary cancer syndrome that is with incomplete penetrance. Afflicted individual carry a germline mutation to one of the fumarate hydratase, or FH allele, and afflicted individuals can develop uterine fibroid, cutaneous leiomyoma, and renal cell carcinoma of type 2 papillary morphology. So HLRCC is a very rare tumor, but typically very aggressive and is known to resistance to all kinds of therapy. So like all hereditary cancer syndromes, HLRCC do have a sporadic counterpart. And when you look at the sporadic counterpart, HLRCC, they rarely present with fumarate hydratase mutation. So what is the molecular similarity between the two? To answer this question, we published a series of papers that show that both hereditary form and a sporadic counterpart share a common feature, and that is a sustained activation of a transcription factor known as NRF2. And in this slide over here, you can see the staining for NRF2 target gene. I think the slide is wrong over here. But anyway, you can see the staining for NRF2 target gene, AKR1, B10, and NTO1 in the sporadic sporadic and hereditary forms, showing that sustained activation of NRF2 target gene. And we have shown that fumarate hydratase inactivation lead to accumulate of the oncometabolite fumarate, which covalently modify and inactivate negative regulator NRF2, which lead to NRF2 activation. And in the sporadic form, it is actually the loss of function mutation to negative regulators, the NRF2 itself, or gain of function mutation, the NRF2 itself, that lead to sustained NRF2 activation. So more recently, we have been trying to investigate NRF2 target genes that is important for this particular tumor type. And we found that ferritin, so the ferritin genes which encode the different subunit of ferritin, are both NRF2 target genes, and they're very important for HLRCC cell growth. If you knock down this gene, it will lead to growth suppression, and prolonged knockdown of this gene lead to cell death. And incidentally, through a different study, we use a machine learning method. We found that HLRCC cells are very susceptible to a form of cell death known as ferroptosis. Now, ferroptosis is an iron-dependent cell death, and how this thing works is when there's polyunsaturated fatty acid in the cell and there's labile iron in the cell, the labile iron will generate radical oxygen species, which can oxidize the polyunsaturated fatty acid to form lipid peroxide. The lipid peroxide will, normally is not a problem for the cell because the cell expresses GPX4, which can utilize the reducing power of glutathione to degrade the lipid peroxide and prevent ferroptosis. But if you inhibit glutathione peroxidase using elastin or glutamate, this is a ferroptosis inducer, which reduces cellular glutathione level. It can lead to the accumulations of lipid peroxide and ferroptosis. Now, as I mentioned earlier, HLRCC expresses high level of ferritin, so if we can induce ferritinophagy, we can actually promote ferroptosis. So this is just a slide to show you that this is what we did is we rescued the fumarate hydratase in the HLRCC cell. So we re-express fumarate hydratase over here and then compare sensitivity to glutamate and elastin. As you can see, glutamate, so the HLRCC cell, they have fumarate hydratase mutation is more sensitive to glutamate than the FH rescue cell, and they are more sensitive to elastin as well. And this is just iron chelation treatment showing this is an iron-dependent cell death. So we try to translate this in vivo, and obviously glutamate and elastin cannot be used in vivo. So for this, we actually use a synthetic enzyme known as cysteinase that's created by Aglair Biotherapeutics, and this is actually under clinical trial for cystinuria right now. And what it does is essentially deplete circulatory cysteine and cysteine, and this has very minimal side effect because cysteine is not an essential amino acid, and the cell can normally synthesize cysteine from methionine through the transsulfuration pathway. But in HLRCC cell, the transsulfuration pathway is not efficient enough to synthesize enough cysteine. Therefore, when cysteinase remove all the cysteine and cysteine, it kills the cell through ferroptosis, and you can inhibit the cell death using the iron chelator like DFO and ferrostatin, which is a lipid peroxide quencher. You can also measure this using BODP, C11 BODP, looking at lipid peroxidation, and cysteinase can induce lipid peroxide accumulation in these cells. Another thing we try to do is to enhance this particular form of cell death by using rapamycin. Rapamycin can induce autophagy and therefore increase ferritinophagy that release iron and increase ferroptosis. So being shown over here is the combinations of rapamycin and the cysteine deprivation to show increased lipid peroxidation. So in vivo, you can see the rapamycin itself show a little bit of effect, but when you do statistical testing, this is actually no different from the control, which is the black color line over here. And for the cysteinase alone treatment, again, this is not statistically significant, but the combinations of rapamycin and cysteinase, we managed to get a stable disease. Now, we're currently working on trying to find a better way to increase ferritinophagy through the use of redox-active iron chelator. And we're also working on immune competence syngeneic mouse model for this HLRCT, because ferroptosis is an iron-dependent cell death. So we're thinking about after ferroptosis, the cell death might immune a secondary immune response, or maybe you can test it with a combination with immune checkpoint therapy. And also we are working on looking at systematic screening for NRF2 target genes that's important for tumorigenesis. With that, I'm going to thank my grant support and people who do the work, and thank you.
Great.
Thank you for that. And now Dr. Jack Gleason will be giving us a summary of his presentation on fumarate hydratase deficient RCC.
Super, and thanks for the invite. I'm going to present on our study on responses to systemic therapy for patients with FH deficient RCC. Just by way of background, FH is a Krebs cycle enzyme transcribed from chromosome 1, and in FH deficiency, there's activation of a complex variety of oncogenic cascades, which essentially act as an oncometabolite. And in 2016, the WHO updated the classification of kidney tumors to include HLRCC associated kidney cancer, but really that's a misnomer, as has been shown that FHRCC can occur either with or without a germline FH mutation. So for the purposes of our study, we also included patients with pathogenic or likely pathogenic FH somatic alterations, provided they had evidence of FH loss by immunohistochemistry. We performed a retrospective analysis of all patients at MSK with metastatic FH-RCC, and the primary outcome measure was overall response rate with RECIST criteria applied by a radiologist blinded to treatment type. We identified 32 patients in total who met our inclusion criteria. As expected, they had a young age of diagnosis with a median of just 46 in the entire population, and 23 patients had a pathogenic or likely pathogenic germline FH variant identified. 5 patients had germline assessments, but did not have an FH variant in their germline, and 4 patients did not have a germline assessment. But all of those met the inclusion criteria by having a somatic FH alteration and FH immunohistochemical staining. In terms of our outcomes, there were no complete responses to any therapy for any patient during the study. The most common regimen employed was the combination of mTOR and VEGF inhibition. That also had the highest response rate, as we see here on the top, and that had the longest duration of treatment. In our cohort, there were 8 patients who were treated with checkpoint inhibitor therapy, none of whom had a response, and they all had the lowest duration of treatment. I will point out, however, that we did have one patient with, who was treated with the combination of lenvatinib and pembrolizumab, who had a partial response that was durable and was treated for a period of over 25 months. In total, across our population, the median overall survival was 21.9 months, and the median progression-free survival for first-line therapy was 8.7 months. We looked deeper into the FH alterations, as shown here, and identified that almost all mutations occurred in the lyase domain of the FH gene. And one interesting finding was when we compared to an institutional cohort of clear cell kidney cancer. It's on the left of the screen here. We see that they had a lower tumor mutational burden and mutation count, but they had a significantly higher fraction of the genome altered. This followed similar patterns to the Comprehensive Papillary New England Journal paper from 2016. So in summary, we identified 32 patients with metastatic FH-RCC, 16% of whom had biallelic somatic FH loss. Median overall survival was 21.9 months. We also identified distinct patterns of spread, particularly with local regional and peritoneal spread, which has important implications for their clinical management. The combination of mTOR and VEGF inhibition was the most common therapy employed, had the highest response rate, clinical benefit rate, and duration of treatment. We did see NF2 as the most commonly co-occurring alteration, but there was no statistically significant difference in overall survival. And we did see interesting copy number alteration patterns, which require further investigation. There are more details in the full 10-minute presentation on the website.
So we are running a little bit behind, so I'll give a few minutes for Matt Campbell to give us a brief summary of his presentation, but I encourage the full presentations available on the video site, so I encourage all of you to take a look, and we can always take questions for the speakers on the chat, and I can assign them to the speaker so you have a chance to discuss that with them. Okay, Dr. Campbell.
Thank you, and I have less than 2 minutes, but this was a pilot study with tremelimumab, which is an anti-CTLA-4 agent with or without cryoablation in patients with metastatic renal cell. This is a post-hoc analysis looking at patients with clear cell versus non-clear cell histologies. This was the basic trial design. What you can see is that both arms had 9 patients with clear cell, and then patients with non-clear cell histologies listed there. Interestingly, what you can see, particularly in the middle swimmer's plot, is that the patients, regardless of treatment arm, were patients that had clear cell histology, which led us to do further analysis. What we found was at baseline are clear differences between non-clear cell, and when you look at the gene expression, clear cell interferon gamma signaling, where has more of innate cells as well as extracellular matrix regulators. When we looked at pre and post tissue, we found in post tissue significant increases in including important subsets of T cells, including cytotoxic T cells that were found on expression and immunohistochemistry, and have far more details in the whole presentation, and more than happy to take any questions, a poster session or other questions. Thank you.
That was tremendous, like an auctioneer there. I want to thank all the presenters and the panelists. I think this was a terrific session, and unfortunately, I think we're out of time. Maybe if there's any final comments from our panelists or our presenters, I think we might have 1 or 2 minutes left. We've been extended. If not, then I think y'all did a great job. You should be congratulated. This was outstanding. Thank you very much.